Hi, sorry I'm a little bit late. I had some technical difficulties.
You are right on time. Welcome, David. So happy that you could join us.
Yeah.
We are recording, so you might have seen the button. If you will click on OK with that, and we have Diane joining us as well. So welcome. We are going to get started. I was mentioning as you are coming into the room, if you wouldn't mind just introducing yourself, let us know what your name is, where are you joining us from today, and what is one thing that you are celebrating, whether today, this week, this month. You see my balloons behind me. Love to celebrate and want to be able to celebrate with you all as well. So happy Friday. My name is Naomi Williams. I am the Patient and Family Engagement Specialist with PFCC Partners. My assistant is with me today. You might hear Noah in the background. He is super excited that it's Friday. We are recording, and this recording, today's presentation, will be up on our YouTube channel. Be sure to subscribe to it, as well as there's a live transcript available. You can enable the closed caption as well. So PFCC Partners, this is what we're all about. You see our mission and our vision is to create a health system that is transformed, one that works with people and through communities as a partner in their well-being. Excuse me. We catalyze system improvements by centering that human experience of health. And we absolutely recognize the critical role community engagement must play for every effort at delivering health equity. So when we think about healthcare, we know how complex the US healthcare system is. There are lots of people, hundreds of agencies and organizations, and a lot of money that makes this a complex system. And often it makes it difficult for people to access and to navigate, to align with their needs, their health priorities, and their preferences. So we at PFCC Partner believe that a system that centers care and the care processes on the person, that human experience, has the potential to reduce complexity and advance the make us humble, culturally humble within an equitable healthcare system. Here at PFCC Partners, we recognize the need to be open and to have space that is open for patients, family caregivers, and community voices to drive the improvements in this complex system. And with that, we have our PFA network. We know that the voices of patients, family members, and community members are a huge catalyst for the improvement of systems change. Our team has decades of passionate experience partnering with healthcare systems and leaders, engaging those with lived experiences in the efforts to improve the healthcare systems. So through our PFA network, if you are not already connected with the network, I invite you to join the network. The PFA network helps to fill the space in being able to create the change within healthcare systems. It's a community by patient family advisors for patient family advisors. It's using the lived experiences to influence healthcare improvement. Some of the opportunities that are within the PFA network are engagement opportunities, being able to connect members with projects within healthcare systems. There's a vast community of individuals across the globe that are able to exchange skills, ideas, as well as skill development, being able to impact learning and strengthening, sharpening those skills. I am so excited to bring our presenter to you today. We're talking about readmissions from the safety net, who is a work group comprised of David Brady, Diane Creel, if I mispronounce your name, please forgive me, and Dr. Umair Jabbar. David Brady, who is an MBA, MSN, and RN, has been a registered nurse for 27 years and is the Director of Quality Improvement for hospital-based services. His clinical background includes intensive care, case management, disease management, hospital operations, managing the bed access program for a 500-bed tertiary care center. He has experience as the transplant administrator of solid organ transplants at 2 Chicago area teaching hospitals. He has been working in quality for the last 7 years in a variety of quality and performance improvement roles. He has been at Cook County Hospital since May of 2021. Diane, an RN, MS, CNS, has over 25 years experience in the clinical, I just lost my place. Over 25 years experience in the clinical and operational development, implementation, and program management of care, coordination, care management, and population health programs. She has led multi-sized projects, including statewide implementations of Medicaid DM programs in multiple states and CMS demonstration pilots. She has been the Director of Complex Care Coordination Programs for Cook County Health since December 2017. Dr. Jabbar has been an internist with Cook County Health. I've stopped sharing, and Dr. Jabbar, if you would like to bring your slides up or begin to start sharing your screen. But Dr. Jabbar has been an internist with Cook County Health for almost a decade, both within the ambulatory and inpatient settings. His insights from those experiences serve as the foundation for his current work in improving the care of vulnerable patients transitioning across those care settings. He currently serves as the co-chair of the Readmissions Reduction Work Group for Cook County Health since 2018. Dr. Jabbar.
Okay, thank you. Hopefully everyone can see my screen. Thank you, Naomi. We'll just begin. So our objective today will be looking at the impact of readmissions and the healthcare systems, because ultimately, this is it's such a broad problem. We want to look at what are the factors that affect, what are the characteristics that affect readmission. So what are the individual characteristics as well as systemic, and then looking at what are the key strategies to reducing readmissions within a safety net setting. We have to make sure we understand readmission. So readmission is a return back to a hospital within 30 days of discharge, and this is an unanticipated return. They do allow exceptions for things that you can't avoid, such as you need to get surgery, you need to come in for your chemotherapy. But this is a reflection of the quality of care that a hospital might provide. Did we set up you to have success after your hospital stay? Get you plugged into adequate clinic follow-up and such. That's why this is quite important, and it's taken as a measure of the quality of care that the hospital provides in that transition during the vulnerable period. We know the impact of hospitalization is significant on patients. The graph on the chart on the right shows progressive hospitalizations over the course of time for a patient who has a failing heart, and their quality of life suffers during the hospitalization, but it never recovers back to the baseline, even after they get temporary stabilization of their condition. So ultimately, each hospitalization is a detriment to their quality of life, ultimately until their last stage of life. We know that medical errors occur with each hospitalization. Almost 1 in 2 patients suffer from a medical error. We have adverse events with relation to what we do in terms of procedures, in terms of drugs, in terms of tests that we do. Confusion affects 1 in 3 of our elderly patients. This is something that we struggle with, especially in this day and age, when we have restrictions on family members being able to visit. So we're seeing more of that even now, more than ever. Many times we acquire infections from the hospital 3% of the time, bed sores. We have to sometimes use restraints, even though we know that this is the last resort, but we have to make sure we don't harm patients further. But that in and itself is a harm. And then falls are quite common, blood clots, and ultimately the reduced quality of life, as I mentioned. There is a syndrome that has been by Harlan Krumholtz called post-hospitalization syndrome. So this is not disability from your disease itself, but disability arising from the hospitalization itself. And we know that many of our elderly, almost 1 in 3, suffer a disability related to the actual hospitalization, not because they're diseased, but because they were actually in the hospital. And the chart on the right shows what actually happens to patients. When they leave the hospital, about 1/3 of them have a disability. And what happens at the 1-year mark? Are they doing better? Only 1/3 are actually back to how they were before the hospitalization. More often, they end up dying within that first year, about 41%. So it's quite significant, the impact on the patients that we take care of. When we do surveys of patients, what is their experience, lived experience of readmission? There are 2 major themes occur. One is one of exclusion, where they feel powerless, they disagree, they feel disregarded about their readiness for discharge. Oftentimes they felt that we discharged them too soon and they weren't ready. There's also the feeling of uncertainty. I feel that the hospital is safer. How am I going to adjust to my new normal? I don't have adequate help at home. All these uncertainties are on the backs of our minds of our patients, even though we might be even talking about their immediate medical needs, but these are the things that are going on. And we need to make sure that we give voice to these and address these uncertainties. What's the impact on healthcare? This is something that before 2009, it was recognized as a problem, but there was no real incentive to actually do anything about it. There was many of our hospitals were actually earning 1/4 of their income from readmissions. The more you did, the better, the more income you got. In 2009, it was estimated about 1 in 5 patients were rehospitalized, and it was costing Medicare and Medicaid $17.4 billion. And again, no reason for a hospital to provide better care and help that transition to the outpatient setting. If they came back in, you could just charge inpatient prices, and you'd get that funding as well. So in 2000, in the Medicare Payment Advisory Commission recommended to Congress that we set up incentives for hospitals to do, health systems to do better. So in 2010, Medicare started posting public ratings of each hospital system. So now you can actually go on Medicare.gov and look at each hospital and see what is the readmission rate for each hospital, ours, the hospitals across the street, and you can get a sense of how well do our health systems prepare you for discharge? How well do they prepare you for self-management, getting you plugged into lower cost care settings, and ultimately keep you out of the hospital where you're more likely to get all the adverse events that I mentioned. Not only is there a public shaming component, but in 2012, they added penalties. So if Medicare is paying us a certain amount of money for the hospitalizations that we have, they can claw some of that back, up to 3% based on our readmission rate. So if we have higher than other hospital readmission rates, we can get penalized for the quality of care that we're providing. This was rightly so, researchers noted that this could be quite detrimental to safety net hospitals such as ours. Safety net hospitals are the ones, there's various definitions, but they're generally hospitals that provide a disproportionate share of charity care, or they might have a high Medicaid population, low income, less resourced individuals. These are the hospitals that often struggle financially, and now with these payment penalties, you might have additional challenges because payments have been clawed back, and then also you already have less funding than other well-resourced hospitals. So it raised a concern across the United States that this was going to compound an already existing problem. Our hospital itself is the Stroger is the flagship of our health system. We're one of 2 hospitals in the health system, but it's the biggest one. We have 450 beds with over 700 providers, and we take care of patients regardless of the ability to pay. That's we provide more than 50% of the charity care in our county. And again, our mission is attracts the same vulnerable patients that are most at risk for readmission. Were we to be worried? Well, we were. If once the public ratings came out, we were worse than other hospitals. We're only amongst 265 hospitals that were worse than average. And ultimately that put us at a 1-star rating. We're only 5.7% of the lowest hospitals, and we had a right to be worried that our publicly doesn't bode well for us, as well as our mainly clawed back. In addition, our hospital is relying less and less on taxpayer funding. So our hospital is now increasingly on its own 2 feet and relying on the newly insured Medicaid population. Only 5% of our budget now is coming from taxpayers. The newly insured Medicaid population now has choice. They can go to any hospital because now they have insurance. So when they look at the public ratings, why would they come to a 1-star hospital such as ours? So we would lose the patients that we historically have taken care of. In addition to that, there's capitation where we're going to get paid for a certain disease state, irrespective of how long or how complex that patient might be. So we have to make sure that we're providing good quality of care because the reimbursement for a certain disease state would be fixed. So for all these reasons, we absolutely had right to worry. We have to look at, who are the patients who are more likely to be readmitted, and what are the systemic level factors that matter. Again, we're right to be worried about these new changes for readmissions. So looking at the demographics, what are the factors associated with readmission? It's older individuals are more likely to get readmitted. Men, as well as from race standpoint, Black race has been associated with the higher readmission rate. More so, it's the socioeconomic factors, such as living in an economically depressed area, having social connections that are few and far between, living alone, not going outside, many of the things that we're seeing in our health system, as well as low health literacy. And then there's other things such as dependency, so requiring assistance with feeding, having pressure sores, poor mobility, all the things that we see in our that walk through our doors. These are the things that will make us more likely to have more readmissions than a health system taking care of more affluent patients and resource patients, as well as the disease state. So related to this, we have patients who are malnourished because of various social determinants, access to food, poverty, all these things affect that, as well as untreated mental health disorders. We see more of those in other hospital systems, as well as advanced cancer. We get patients who have unfortunately not been able to get care until they're at stage 4 cancer and it's already spread. And how do you properly care for that patient when you're already starting at such advanced stages? And then untreated dependencies for substance abuses. And then, the treatments that we do, again, our patients are quite complex. They need a lot of appointments. Do they have transportation? Can they make all these appointments? How do you work a job when you have all these appointments? So these are the things that make it much more likely that a patient's going to get readmitted when they have multiple medications that we're giving them, and risky medications as well. So the more medications, as well as some of these more complex regimens that you need to have good health literacy. You need to have social supports to be able to, use some of these things, such as insulin. The systemic factors as well. We know that there's a lot of systemic factors that would make it challenging for us to address readmission, including follow-up availability, follow-up quality. So we have a lot of patients that we need to see, and we don't have as many appointments available for them to be seen. So we knew that was going to be a challenge, as well as communication. When everyone's so busy, it's very difficult to reach out to other health systems, as well as across even our own health system. How we structure things, all the different other things that are listed here. So we know from the literature that communication is a huge factor in readmissions. This paper looked at how well do we do this. This paper showed that almost 1 in 5 patients, the physicians that are taking care of the patient in the hospital are not discussing the care of that patient with the patient's primary care, almost 1 in 5 of the time. As well as the summary of the hospital stay is not available to the primary care physicians of our patients. This study put this at 66 to 88% of the time at that first visit after the hospital stay. The summary of the hospital stay was not available to the primary care physicians. And ultimately, the primary care physicians said that this was affecting their care 25% of the time. Many of these summaries were incomplete. Almost 65% were missing critical information that would matter. Systemic things, I mentioned follow-up. Follow-up is absolutely important. This study speaks to that this looked at a New Jersey Medicaid population and showed that, getting patients in, which is going to be a challenge for a safety net hospital, does matter. Follow-up within 7 days, reduces the chance of readmission, almost, 5% percentage points. And then, it's easy to do if you have a medically simple patient population, but when you have a complex patient population, it does matter when you see them. So within 7 days, after 7 days, the graph on the right shows that the risk of a sicker patient coming to the hospital markedly rises after 7 days. Whereas if you have a healthier population, you can, see them much further out. You can see them up to even 30 days out, and their readmission risk doesn't climb markedly. So we knew that these were going to be significant challenges for us, that we have a sicker patient population, and we also don't have availability to see them within that 7-day time frame. We wanted to look at this, we wanted to make sure that we understood, is the literature also commensurate what we were seeing in our hospital system? What were our patients telling us? Ultimately, our lived experience in our health system for our patients is how we will, make the most meaningful change for our patients. So we want to make sure that we involve our patients. Nothing about me without me. And we want to make sure we pursue the patient's perception. This is a key tenet of our work. So we called our patients, and through our work, it's very difficult to reach our safety net patient population. And in these surveys that we did, we weren't able to reach almost over 3/4 of our patients. In other studies that we've done, other projects that we've done, generally you can expect to reach about 40 to 60% of a safety net patient population. This is because many don't have access to stable housing, stable phone lines. There's a lot of reasons why can't reach them. There's distrust. Who's calling me? Is it someone from? Is it going to be someone who is going to question my immigration status? So for all these reasons, we understood that doing things after discharge was going to be a challenge because we're only going to be able to reach less than half of our patients. When we talked to our patients, they told us that they often were not finding out, we didn't even talk to them about their diagnosis. We treated them, but we didn't do a lot of that self-education. So a lot of times they didn't even know what we had diagnosed them in the hospital. They didn't know any of the symptoms to watch out for when they were going home. Over half said that, I didn't know how to check on myself. Am I doing okay or not? We are discharging patients, again, expressing with that uncertainty, that feeling of being disregarded. Many of them were not even feeling better by the time they were going home. almost a quarter were saying that I'm feeling the same or worse. So we weren't addressing their needs in terms of pain, in terms of their short breaths and such. And many were not taking their medications appropriately. So many were taking medicines that we didn't want them to take, or they were still they're taking medications we had taken off them, or they were taking them at the wrong time of the day. Many different medication errors were occurring. And then appointments, we have limited amount of appointments. We want to make sure that they know about them as appointments, but many over, about a third of patients were expressing that they didn't know that they had an appointment, or that we never even gave them an appointment. So these were significant challenges, and we were doing very poorly on getting patients appointments before they went home. We were often doing this after they went home, and again, it's already hard to reach them after they go home. So we were issuing appointments, after they go home, or they were canceling them, making changes, and many times they weren't aware of those changes. So a lot of work on the back end, on the after discharge, but a lot of it wasted. And this program that we're talking to our patients, we're also helping them. When they were expressing concerns to us, we weren't doing this just purely to survey what were the issues in our health system. We wanted to know where we need to escalate most. So many of our escalations came regarding appointments, getting them plugged in to our clinic sites. A lot of the issues related to pharmacy, making sure getting our prescriptions dispensed. Patients would leave our wards, go down, and leave without picking up their medications that they weren't aware. And then there were just simple concerns about reaching out to our clinicians. We were notoriously difficult to reach as a health system through our phone trees and just getting a hold of someone. So these are some of the things that we learned by talking to our patients. And this is a likely shared experience across many other safety net institutions. We looked at, what are the patients that what were the demographics and characteristics of our patients? So most of them were middle-aged. Over 90% were either African-American or Hispanic, and we had a significant insured population. Historically, that had not been the case, but again, with Medicaid expansion, we were seeing over 60% have been insured, and less so are now uninsured. And most of them were actually seeing us, so most of them were empaneled within our health system. So that was nice that, if we made changes, we can, make sure that we can follow these patients across different care settings. We knew that health literacy, qualitatively, we knew this was a problem, but we put numbers to that. We found that a little less than half had difficulties with health literacy. There were significant barriers to learning in terms of language, in terms of vision and hearing, physical limitations, and these are likely underestimates because these we assessed through nursing intake when patients were admitted, but it spoke to the magnitude of the problem, and again, probably underestimated. This is fairly accurate in terms of how often were our patients dependent on others, and again, we know dependency makes a difference in readmissions. Our safety net patient population had about a third were reliant on others, but we were seeing that significant numbers were actually not improving, or they're declining when they had these disabilities. So 11% were declining, and 74% we had no improvement because of the hospitalization. So a lot were going home in the same condition that they were in. And we weren't really, addressing their pain. Again, this is speaking towards what our patients told us over the phone. But we saw, through our review of our records that most patients were saying that their pain score, decreased by 1. The average decline when patients had pain, the pain score declined by 1, and almost a third of our patients were saying that they were not much better off after they left. And we, again, knowing that polypharmacy matters for readmissions, many of our patients were increasing in how many medications that they were taking by the time they were going home. So if they came in, 66% of our patients were coming in with on 5 medications, and by the time they were going home, almost 73% of our patients were going home with more than 5 medications. And again, that's just a right recipe for adverse events and confusion, and ultimately harm to the patients, either to the medicine itself or having to come back to the hospital because something went wrong. In our safety net population, we also found that many of our patients were not coming back to our hospital. So when you look at the rest of Illinois, when patients were getting discharged, many of the patients return back to the same hospital. Our patient population was a little bit more, I guess, migratory. They might go to other health systems to seek care. And again, I think this reflects that there's newly insured patients who now have choice, and this poses a problem for a safety net compared to other hospitals, because when we put in programs in place, oftentimes those programs are housed within our health system. And if our patients are going to other health systems, then it just becomes a little bit difficult to, as we know, health systems don't talk to each other very well. So this would be a problem for our system, that if our patients are hopping around as opposed to coming back to our own doors, where we can capture them and help them get the assistance that they need. When we look at some of the characteristics of the health system, what made it challenging, again, we found that the more patients that a type of service took care of, the higher their readmission rate. So this speaks towards, as you stress the system, as you have more patients coming through that you're taking care of, you're more likely to do rushed and shoddy care potentially. You might rush that discharge because you have so many waiting in our emergency room. So internal medicine, which is our largest service, has the highest readmission rate. The patients are more complex, but it also reflects volume. You can see pediatrics, lower volume, more time to do proper care in the hospital, as well as that transition period. We also looked at our appointments, and looking at when you schedule an appointment within 14 days, we know that more patients are likely to show up because you catch them in that vulnerable period. They're more likely to come in and get checked out. The more further your appointment is, the less likely the show rate. So we knew that services in our hospital that were doing a better job of this, they were getting higher show rates. So we know that this is something that we need to work on, especially in internal medicine, which has the highest, largest group. And then looking at the hospital summary, were we providing a hospital summary? We were doing a fairly good job of that, and 92% of our patients were getting their hospital summary finalized within 30 days of discharge. But many of our patients were not picking up significant, over 10% of our patients were not picking up their medications. So we knew that this is something that we would need to work on. And then we were also not communicating very well. So if there were a lot of tests that were pending at the time of discharge, they were not back, and we weren't really communicating them to our primary care physicians. Only 70% of the time was it communicated to their primary care physician. I think that reflected a lot that many of our patients came back to our health system. So there's this assumption that our primary care physician will see the same records, but that's not always the case, and a lot of times things do get missed. So we and then we looked at, what were the reasons? Were readmissions preventable? And majority actually are not. And this is commensurate with what we find in the medical literature, that only about 25 to 33% of our readmissions are preventable. Most of the time, the readmissions are for legitimate reasons, such as the patient having a complex disease, and there's nothing you can do because it's the actual disease itself that's causing them to come back to the hospital. But there are, areas that you can intervene on, the social determinants of health, such as housing and substance abuse, just helping them leave again, patients that leave against medical advice. Why do they do that? A lot of them were leaving because they also have substance use disorders that are going unrecognized. And then we have a large number of patients that come into our health system because they have advanced liver disease. They can't get a transplant, and we were seeing that as well. So these were some of the things that we knew that were problems in our health system. But now looking at that preventable component, right? How do you prevent if only about a third are preventable, what can you actually do to prevent them? So we found in our work that outpatient care likely has the most meaningful impact on preventing readmissions. We were looking at how far were our appointments. Most patients were going home 25 to 30 days before their follow-up visit. So a lot of, that's a very vulnerable time, 2 weeks, 3 weeks, that a lot can go wrong. And it made sense why they were having to come back to our hospital. They, may have run out of medication. They may have misunderstood something. Way too far, we're wasting our patients. Patient and family engagement is another thing that we found that had we done better on this, we would have prevented our readmission. So, making sure that we actually assess where should a patient go? Do they have adequate social supports, adequate home supports, getting them equipment such as a cane or a walker, getting them set up for a home nurse to visit and do education. These were common lapses that we're seeing in the preventable readmissions. And then doing a proper medication reconciliation. A lot of our patients have old medications that are laying around at home, as well as the new ones that we're prescribing. All these complex regimens, there's a recipe for mistakes, and that was not the fault of the patient. It's our fault for not making sure that we weren't educating and doing that proper reconciliation. Then, further self-care, such as how do you take care of your wound? Do you have the supplies to take care of your wound? How do you, if you have a tube coming out of you, a catheter, how do you work that catheter? So these are some of the things, the basic things that, we were not doing very well, and we need to make sure that we engage our patients. And then other things such as symptom control. So, symptom control, the common symptoms being pain, as I talked about, shortness of breath. And a lot of times, health systems focus on something completely unrelated to what the patients actually came in for. Patients come in with symptoms. I have shortness of breath, I have pain, I have this. But then we focus on technicalities. What does the lab show? What does the imaging show? And we focus on that, but oftentimes we don't circle back to, did we actually address your chief complaint? And that's what we found in our work, that we weren't actually doing that. And other things such as palliative care. Sometimes patients have advanced disease that you can't do anything about, but we want to make sure that we talk to our patients that in a honest manner and say that you have advanced disease and you would be better off not suffering the ills of repeated hospitalization, but getting palliative care. And we weren't doing that very well. And then there are other patients who purely they needed addressing some of these other conditions, such as psychiatric illness and substance abuse and some of the social determinants of health, such as housing and security. So knowing that, listening to the voice of the patient, looking at, what were our patients telling us, where were we not doing well as a health system? We want to make sure we use data and that qualitative and quantitative to drive our work and make sure we don't want to address the whole universe, but target our work so that we, if we want to reduce our readmissions, we want to make sure that we do it on where it's going to have most impact. Looking at preventability, can we actually prevent? Again, the research says that 1 in 4 are avoidable, and that's what our own work had shown. And we want to make sure that we use the literature to guide us, right? And what matters most? What's the most cost effective, right? So we learned that the literature says that teaching patients to help themselves and providing those supports after discharge, that's the single most effective single intervention you can do for a patient to prevent readmission. But other things such are providing follow-up, and that really matters after that first week. You got to make sure patients are plugged in, or else they'll just come back they'll need to come back to our emergency room. The types of interventions that we saw available to us in the literature, again, centered on the patient, and that was the most important, as I mentioned. If you do it doesn't cost too much to engage the patient. Just do better counseling of the patient, get them better self-management skills. That provides actually a net savings to health systems. We found that in the literature, you can save $1,714. You don't have to expend a lot of money to do that. Where you might have to spend a little bit more money is, providing extra care beyond the primary care physician. So that also has been quite effective in the literature. So doing home visits, providing phone support. And there's other things such as assessing a patient's needs in the hospital, what, housing insecurity, food insecurity, those things, and then communicating better, as well as doing the medication reconciliation. But overall, the top 2 are the most effective. But overall, the more things you incorporate, more of these things you incorporate, the better chances of success of your program. So again, we wanted to target and we wanted to use what we knew about from the literature, from what our patients were telling us, to create a program. So we targeted the patients that were readmitted the most, which is heart failure. And again, this is a condition that if you do well with your ambulatory care, you can actually prevent readmission. So we found the same things for these patients, that many of them were not able to come into our clinics. They needed education, they needed better medical care, better medication reconciliation. So we had to make sure we engage a team and align within ourselves, as well as what other externally what Medicare and Medicaid looked at. So we recorded a number of different individuals. It takes a team to do this work. So we had our inpatient physicians, our cardiologists, our pharmacists, our care coordination staff, as well as our appointments center. And we created a shared population that everyone is looking at the same list. And this list was crafted based on how Medicare and Medicare defined this heart failure population, so that if we had an impact, we knew they would have an impact in how Medicare and Medicare looks at. And we used Project Red, which emphasizes certain things, but the key things that to take away from the literature is that patient education is very important, post-discharge support, and early follow-up. So with that, the self-management, we engage our patients by we standardized the teaching material that we were using, so we can use it across our health system for these heart failure patients. So what they see in the hospital is what they see in the clinic, so that they get reinforcement and they learn over time. We had in-service for our bedside nurses, so that they're really expert on what do you need to tell our heart failure patient during the hospital stay on day 0, day 1, day 2, and they go over nutrition, they go over different things through the hospital stay, so they're not doing that at the end. We also have a transition care team, 2 nurses who introduce themselves at the bedside. They text their information to patients, and the patients at that point, have the number right in front of them, so that they can call our transition care team once the patient goes home, or they know who's calling them when the patients are at home. So that's right in front and center. So we want to make sure that we do a warm connection with our patients before they go home, because we don't want to lose them with our doors. We also want to make sure that our patients get their medication. So we have a pharmacy. Our patients go down to the pharmacy, but they weren't getting their meds. So we created a system before we had to use phones. Now we have a dynamic system where we can text our pharmacy that we're discharging our patient. We do this actually ahead of time, and we let our pharmacy know this patient's coming. Is there going to be any issues with filling this medication? Is there going to be prior authorization needed? Are you not going to be able to dispense any of these medications, so that we make sure that the medication is ready for the patient when they show up to the window, so that the patient doesn't leave out of frustration. So with this, we've improved how often patients are getting these medications. We also want to make sure our patients go home with appointments. We don't want to do this after the fact, as we were doing. So we started educating our physicians. We started incorporating requesting appointments at the time of admission. Don't wait till the very end. And we saw that by doing some of this, we increased how often we were doing requests prior to discharge. We've come up and stabilized that process, and still there's more work to do. And our nurses were providing support after discharge. So they call 48 to 72 hours. They reinforce everything that we've done in the hospital in terms of education. They troubleshoot and provide support if they didn't get their medications, if they didn't get any equipment. And then they also do review. What appointments do you have coming up? Do you have any barriers to making those appointments? Do you need transportation help? So all those things we knew that our patients would need help on. Even if we did an excellent job in the hospital, we knew there were going to be lapses, and this is where we could do this recovery. We had to rethink our resources as well. We knew that we had medications was another area that we were not doing very well in. We only had 3 pharmacists across our medical teams. Again, with our safety net hospital, limited amount of resources, we could commit to this. So then we had to rethink who could we employ. So we had students. They were quite enthusiastic. They wanted to do something more than just answering questions on rounds. So we harnessed their enthusiasm and had them lead how could we do this better? And by having them lead this program, they're calling patients, they're seeing patients in the hospital. More and more of our patients are seeing our heart failure pharmacist and getting that counseling through, specialized pharmacists, as opposed to just what I might say as a physician. And we worked with our cardiologists as well to make sure that our appointments are happening within 7 days. So there are selected patients who, not every heart failure patient needs a 7-day follow-up, but the ones who are actually in the hospital, we want to make sure at least we see them within 7 days. So this looks at the whole heart failure population, and then a subset of them will need within 7 days. So we started seeing improvements once we had our nurse doing the scheduling rather than relying on the phone tree. And then we also had modification of our cardiologist schedules where they saw patients in the hospital 1 week, and then the following week they were back in the clinic, so they could see the same patients that they were seeing in the hospital, in the clinic, the very next week. And with that, we saw, again, by educating our physicians to do this early, starting this all before, on admission and not waiting till the very end, we saw that more patients were going home with appointments. Our show rate improved to these primary care appointments. So internal medicine as well as family medicine saw over the course of time that because we're doing this early, we know early follow-up, patients are more likely to show up, and sure enough, more patients did start coming to our primary care appointments. And with that, our heart failure readmission rate has gone down. It's gone down to 13.85% compared to our other hospitals. And we used to be at 16.3%, so a 3% reduction. And we've sustained that for several years. This has earned us the Heart Failure Recognition Award from the American Heart Association, the highest distinction. We have come down to a no different than national rate, and that's earned us, that's contributed to our 2-star rating. We also have no payment penalties for 2023 because of some of these efforts. And key takeaways from this presentation is that readmissions is quite harmful, markedly so to patients as well as to health systems in terms of payment, in terms of our reputation, as well as just overall, we want to make sure that we do a good job, right? All of us are we're in it to do, we want to make sure whatever we do it well, right? And we want to make sure that so it's harmful from that standpoint. They're preventable, but you have to be targeted. And then you have to understand that readmission is not just within the walls of our health system, but it starts beyond. Our patients' social determinants of health determine the risk of readmission. And then you have to understand that none of this work is possible through individuals. It's really working as a team that we're able to achieve some of this. Thank you for your time, and I'm happy to take questions.
Thank you so much, Dr. Jabbar, for that rich presentation. If you are okay to stop sharing, and I will, there were several questions that were generated during your discussion. One, so you had talked about nurses as part of the team. And one specific question is, what role do nurse navigators or similar programs play in avoiding readmissions? So don't know if you all had specifically nurse navigators, but are you able to speak a bit more to that?
Yeah, our version of that is the transition care team. Basically, again, and we want to make sure they see the patient, introduce themselves, and earn the trust of our patients in the hospital. And they are the same ones that will call the patient afterwards, 2 days later, and they while the patient's in the hospital, they help the patient, they advocate on behalf of the patient. Sometimes I might not know that a patient needs a walker, for example, so they'll reach out to the medical teams while their patients are in the hospital, and then also make sure that anything that we promise the patient is enacted by the time the patient's home. And if it hasn't, then they troubleshoot on the back end as well. But that in the literature, that's a one of the key strategies that a lot of readmission reductions programs have used, including ours.
Thank you for that. You another question, you had mentioned about using the students. And so there is a question, do you think that your patient population could benefit from community health workers? And if so, are you able to recruit them, and how are you retaining them?
So I'm gonna let Diane Creel, who's my co-chair, take that one.
Sure, Diane Creel, thank you. So currently we do not have community health workers tied to the transition of care nurses. What we do have are complex care coordinators, nurses, social workers, and community health workers who are out in the field and actually tied to our ACH and our community care clinics. The goal within the second quarter of this year is to support our transition of care nurses with community health workers. As far as recruiting and retaining, I've had really good luck. I've had the same team of community health workers for 5 to 6 years. So I think part of that is the mission and what we do, and frankly, variety, right? Recruiting is just like everything else right now. It's a pistol to try to recruit healthcare. So community health workers are no different. In fact, I would argue they're equally, if not more, difficult to recruit for at this point. So I hope that answers the question.
This is David. I'd like to also touch on that briefly. So first of all, Dr. Jabbar and Diane have done an outstanding job on the readmissions program. Dr. Jabbar is very modest for the work that he's done. He's been leading this readmission team along with Diane, and they've done some really outstanding work and some really great outcomes. I wanted to touch on the question about community health. One of the other things that at county we have is the Healthcare Equity Institute. It was something that was started recently as part of the organization, has our commitment to health equity and Joint Commission's new standards as it relate to health equity. As a matter of fact, the Joint Commission is going to use our particular program as a demonstration program for health equity for other hospitals around the country. There's a lot of commitment, as Dr. Jabbar said, also to supporting the community. Readmissions is one group of our high reliability organization program. We have a whole sequence of groups that we work with: patient experience, mortality, as we know, readmissions, process of care, clinical documentation, and then HEDIS for our ambulatory groups. So there's a whole slew of things going on, and readmissions is one example of it. Again, Dr. Jabbar and the team and everybody have done a really great job. But I want to bring up the health equity thing because that's a very important part of what we do now. So that was it.
Thank you, David. As you were talking about the prevention of readmissions, there's a question: is there any research and or studies on the return on investment of preventing readmissions and the resources staff or FTEs needed in that regard?
So in terms of one of the slides I had of that paper actually looked at the economic cost to a health system trying to implement different types of interventions. Some of them, are going to be much more labor intensive, require more resources. Overall, there's a net, gain to the health system in terms of savings for the patient engagement initiatives that are the most cost effective. So again, on that slide, it estimated about $1,700 per patient if you use primarily that type of intervention. Other things such as hiring more staff, that's going to be a little more, doing home visits, so you could, in that paper, the range, there were some interventions that basically do cost more, so that you can expect some interventions that is going to cost your health system about $300 to $400 per patient. Again, those are the more labor intensive ones. But if you use existing processes, but improve them, help the patient help themselves, and that's going to have overall net savings will be cost effective. I haven't seen any papers. I didn't come across any papers that particularly look at the number of FTVs required, but I'd be happy to share that paper that talks about the economic cost of different types of interventions.
Thank you. If you have any additional resources, because after this next week, I'll send out follow-up information so I can include it in there. And just so you all know, I see all the questions coming in, and y'all have amazing questions, and we may have more questions than we have time for. But I'm going to get through as many as I can. And then whatever we don't get through, Dr. Jabbar and team, I will send them to you. And if you're available to answer them, we would greatly appreciate that. So one of the other questions here is, what areas have your team seen the greatest gains in patient engagement or outcomes with the safety net population? With your safety net population?
It's really, in terms of, again, just because we focused particularly on the heart failure population, right? So that is quite contingent on, taking medications appropriately, knowing how to do, refills, how do you, why is it important that I have to take 5 or 6 different medications, right? So it's just that basics of, you can stay out of the hospital, you can live as normal life as possible, and live as long of a life as possible with that. So, it's really that basic disease education, I think, that is the most important, so that patient understand, why do I need to pick up my medication? Why do I need to take my medication? Just by doing that alone, that will keep a heart failure patient out of the hospital. Yes, you get them appointments, that's been impactful, but just engaging them, helping them, learn about the salt intake and all that, is quite helpful.
And then with that, I know you had a slide. I don't remember if it was included in this presentation or taken out, but the question is, do you know what the top 3 departments with the highest readmissions are or were in your health system? And why do you think that was?
So it's all, in general, internal medicine, because, we see the most complex patients, those are going to be the highest readmissions. This is in the literature as well. Even surgical patients, when they get readmitted, oftentimes it's for a medical reason. 75% of times surgical patients discharged after their surgery, they're back in for a medical reason. So for our health system, the top 3 conditions that we were seeing, again, is heart failure. After that, it was infection related, so sepsis, and then after that, it's cirrhosis. And again, cirrhosis because a lot of our patients have advanced liver disease and they can't get transplanted, so they have the complications of such.
Do rates of preventable readmissions vary by type of hospital? So a safety net versus university teaching versus community?
I haven't seen any breakdown in the literature on that aspect, whether preventable readmissions. So preventability, there is a difference actually. So if we have data from internally, we have a database that we feed into that compare us versus university hospitals versus community hospitals. So you can see that the rates do differ, and then the preventability also will differ because the prevalence of things that reduce preventability differ, right? So if you have more substance abuse, in your patient population, if you have more housing insecurity, you're more likely to see less preventable readmissions. So that absolutely does differ. I don't have absolute numbers to that, but in terms of how many are preventable at a safety net versus at other institutions. Ours, the estimates of preventability go as high as 80% in the literature, but it's a wide range. But in our work and through other studies we've seen in the safety net population, you're looking at about 25 to 33% are preventable. It's not going to be 50%. It's not going to be 60 or 80% preventable. That some studies have shown in other hospital systems.
Thank you so much for that. You all, I know we are at time and you all have some amazing questions. So again, I will make sure we get those questions to Dr. Jabbar and team. And hopefully we can get additional answers to your questions. Before you leave us, we're so excited to be bringing our PFCC conference back in person on May 2nd at the Endowment Center in Los Angeles. Hopefully it will be sunny in LA. So registration is open. Please go and check it out. We have some fantastic workshops that are in the works. We look forward to seeing you in person. Let's give Dr. Jabbar and team a good hand. Thank you so much for being here. Again, we'll work to get those resources and send that out to you next week. This has been recorded, and I will include that link when I send out the resources next week as well. So a whole bunch of things that you all are celebrating this week and today. So I hope you have a wonderful, a safe, happy, healthy weekend. Take care.
Thank you.
Thanks, everyone.
Thank you.